Okay, so this is chapter 2. We are advanced coding the Carol Buck Next Step textbook. We did evaluation management. I do apologize for how long that video was. There wasn't a good place to cut it in half. It's just a long video. E&M is just tough. So this is chapter 2, medicine section of the CPT. Remember, this book has all of your odd cases, the answers in the back. I will help with your even cases. May not do all of them on these videos. I will try to steer you for every case. We will do some together on these videos, but again, I can't stress how the feedback that I've gotten from the students that I've taught over the years, that taking themselves to the advanced portion or advanced type of cases really helps solidify the CPT manual usage, the HCPCS, and the ICD-10. It all kind of flows together. So it all comes together here. So, okay, medicine section, chapter 2. Just like in the medicine section, this area starts with your vaccines and your immunizations. Remember, I said on the previous video, this book is very good at pulling in some wordy stuff, but it's very concise. It's very much whittled down to that information that is really pertinent for CPT usage. Make note that there is some guidance here on your G0008 and G0009. These are the Medicare administration codes for flu and for pneumonia. Both of these, case 1 and case 2, are going to deal with that. So when you have a Medicare patient and they're receiving flu or pneumonia vaccines, you're going to get the administration code from the HCPCS and not from the CPT manual. Okay? So that's pretty much the guidance here for this case 1 and case 2. Case 3, I do want you to make note here of Z23. This is the global ICD-10 code for any encounter for vaccines. This is the code that you would use, Z23. So you'll see that on some of these scenarios. So these scenarios you shouldn't have any trouble with. They're pretty easy, or pretty straightforward, I shall say. Moving on, we have our hydration codes, and then we have our therapeutic codes for hydration. This area seems like some folks have issues determining the time factor for your infusions or your IV pushes, therapeutic versus hydration, that type of thing. So this really does give good, concise information, helps break down the time factors, explain that a little bit better. This is a great time as you're working through this textbook, the advanced textbook, Next Step. It's a really good time to streamline and hone in on good notes in your CPT manual. Kind of really fine tune them. Okay, so let's look at case 2-4. This is a Medicare patient. For this scenario, it does not appear that we will need any HCPCS because there's not a flu, there's not a pneumonia. This is actually an infusion of saline solution because of dehydration, so they're hydrating them, and it lasted for 50 minutes. So I want to, better put my glasses on so I can see. My eyes are old, and they're really old in the evenings. So let's look at the hydration section. Oh, I thought I was at it, but it wasn't. It should be 963. Just gotta keep going till we find it, because we have some out of order. Okay, so here we go. Here's the hydration, therapeutic, chemotherapy, all of it's in here. This section excludes the chemotherapy, but then chemotherapy will be next. So we know that our scenario is for hydration, so it has to be one of these codes. So now we plug in the information that we have. We know it's an IV infusion. We know it's for hydration. To our knowledge and documentation, it's the first time. And it's for 50 minutes. So this is 31 minutes to an hour. So this 96360 would be our code. So we've taken that information from the CPT and gotten there. So now we need to go to the HCPCS and find the J code. Remember, at HCPCS, the J codes are your drugs and medicines. So we need to find the infusion code for that saline. What did it say? Saline solution, prepackaged 5% dextrose, 500 cc's. So we've got to plug that information in. So here is our J codes and our infusions. So here at J7030 starts infusions of normal saline 1,000. Well, that isn't quite what we did. Infusion normal saline 500. Well, that is the right amount, but it doesn't have the dextrose in it. So here, J7042 has our 5% dextrose, sugar, and is our 500 milliliters. So J7042 is our code for the HCPCS, for the medicine. Then our diagnosis is dehydration. So we need to go to the ICD-10 and look up index dehydration. So I'm going to go to the index. Hopefully I'm staying where I'm supposed to on the screen. Dehydration, and it takes me a minute because I always lose my alphabet. You've probably heard me say that 100 times, it's true. It's amazing how you can have to recite the alphabet to yourself. Okay, so here we go. Here is dehydration, and it's code E86.0. So I'm going to go verify because that's the way that we should do it. E06.0. 86.0. Here we go. So E86.0 is our dehydration. So all of the codes for that would be 96360 for the infusion with our time, J7042 for the actual substance, the medicine that was infused, and then E86.0 for the dehydration. So it's a short scenario, takes a little bit of time to get all those codes. As you practice, you will get faster. I promise. Okay, so 2.5 is similar to that, so I'm going to let you do that one. It's along the same line. Then we go into psychiatry. So here is a psychological eval, and you should have in your psychological eval, or in your medicine section, you should have it marked psych eval. So let's first find that. It's back here toward the beginning. I'm way in the back one night. So here's psychiatry. We should have a code marked, with notes, psych eval. So this would be the first, this is the psychologic or psychiatric diagnostic evaluation 90791. Now, in this, it appears that they did some additional testing and some observations. And we're going to have to code extra for those. And I'm trying to see where exactly in here it talks about that. We've got the so in addition, so right here, we did a 65-minute interview and records review. That would be a part of that psych eval. In addition, they did 1.5 hours of testing, scoring, interpretation, and generation of documentation. So that's going to be, and instead of you watching me, I'm going to get to it. I'm going to already have it, and then you won't see me flipping all those pages because that might be very distracting. So code 96116 is your neurobehavioral status exam. This is what they're talking about. So this would be for how long? This is the first hour. And then if you turn the page, the add-on code 96121 is each additional hour, list separately in addition to code for primary. And they only did 1.5. So I have to read here and see part thereof. Does it say part thereof? List separately in addition to code for primary. It doesn't each additional hour. We don't quite have an additional hour here. So I would only, because I don't have a full 2 hours, I would only code the 96116. Had this said, like some of the codes say, or part thereof, then we could do the 30 minutes here, but I am not seeing that we're able to do that. It didn't give me that each additional hour, so I think you need to have 60 minutes in order to code the second one. So had our scenario said 2 hours, instead of in addition to the 1.5 hours of testing, then we would be able to use it. So those are the codes for the psych eval. And then the impression, serious motor vehicle accident, current, we will work with him to better understand. I'm trying to figure out his exact diagnosis. He also suffers from post-concussion syndrome. Let's see, I just got to read here a minute so that I can kind of get a handle on what his diagnosis would be. I code these as I talk so that it's fresh and you can hear me talking through some of my own, how I'm reading it and how I'm seeing it. So I don't see a great diagnosis there. So let's see here. This is inpatient. Does this tell us who, primarily in regard to his post-concussion syndrome? He had a car accident. I think it's just going to be that post-concussion syndrome because that also is brought here. So he also suffers from post-concussion syndrome. He's been on the ventilator, so that's the root cause of the problem. So post-concussion syndrome is what I would code. So, like I told you in basic coding, when I have something syndrome, something disease, something disorder, I go backwards first. So I'm going to go to syndrome first and work backwards because it's post-concussion syndrome. So I'm going to go syndrome first. So here I'm under syndrome. So now I'm going to go to post-concussion. And I won't take the time on every single one of these. This is kind of what slowed us up on the E&M. So I'll try to get faster. I just want to give you guys a little look at how I do stuff. So here we go. We're under syndrome. Here's post-concussional, F07.81. And if we go and verify that, here it is, post-concussion syndrome. Okay? So that would be how we did that one. Just like in the first chapter, you will come across cases that have a great discussion with them. And most of the cases that have the good discussion, I'm probably not going to go over. I can't do any better than Carol Buck. She really does a good job at breaking it down and why something was coded, why something else wasn't coded. Here's some good dialysis, concise information that will help you get notes in. Peritoneal dialysis, remember there's two kinds. There's hemodialysis and there's peritoneal dialysis. The hemodialysis, I don't have a picture for it, is where you have the AV fistula and you can feel a thrill. Usually you can feel movement because the fistula allows the venous and the arterial vessels to come together and flow together with the dialysis so that it is easier to get all of the blood out of the body and filtered and put back in. Your peritoneal dialysis is just of the belly, just in the abdomen, and you generally have a bag hanging by gravity, and that's how you do peritoneal dialysis, and it can be done at home. It can be done by the patient, by the patient's family, or by home health nurses, something like that. So this is good information to remind you again about the difference in the dialysis and how to code them. Here is a history and physical exam. We did have these in E&M, so this is an E&M code for you to use. That's what you would be coding for, is the physician's time. Diagnosis codes. There's going to be, so the patient got acute peritonitis due to her peritoneal dialysis, so there's going to be a T code to for the complication. This helps talk some about complications. So that's going to be the whole reason that they're encountering medical help for this moment in time, is the complication of that peritoneal device, and then the peritonitis. And then they also have hypertension and end-stage renal disease. So it tells you here, so anytime you have an acute infection because of something else, that's probably going to be a T code or a complication code, just to kind of help steer you where you need to be. These are more dialysis. If you need help with these diagnosis codes, leave me a comment and I can do a video. If I know specifically, I can get on and do a 5 or 10 minute video explaining stuff. I'm just trying to get you used to working through a scenario and then combining your CPT and your ICD-10. Now, again, like I said in the E&Ms, like this case is A, B, C, D, E, F, G. That's all the same patient. So once you get the diagnosis codes here and in places, you can reproduce them. You won't have to keep looking it up. Here's a good discussion that kind of helps with that case. Okay, then we're into the non-invasive vascular diagnostic studies of the medicine section, and here's some practical scenarios. So this is a duplex carotid artery study. And if you see here, it's outpatient hospital, duplex artery test, real-time analysis, right side, hard plaque, posterior wall. So that's telling us what they found. But we kind of need to know what they had done. Like here, Doppler flow analysis. That may very well be in our description when we look up the code. And then they had 50% stenosis. Conclusion, there's some atherosclerotic change, but it is not prominent. Okay? So for this, we need to get to the duplex carotid artery studies. So these are non-invasive. This is just like an ultrasound of the neck. So let's find that section. Instead of going through the pages like I'm doing, you could come here. Remember, we have this index. And so we're probably going to find the non-invasive vascular diagnostic studies. We're probably going to be in this section. So that's 938. So that's a little bit faster way than having to go all the way to the index. Okay, so here, let's see. So they did carotid. So this is non-invasive physiologic. So carotid is going to be, okay, so here we are, non-invasive vascular. I was early. And it was a duplex, correct? Duplex, let's read that again, duplex carotid artery study. So 93880 duplex extracranial arteries. So extracranial, so that's not in the cranium, so that could be carotids. You might want to write here, i.e. carotids. That would be a great tool for you to use to be able to really have a good note there to get you. Here it says they did both sides. So in this, whoops, I'll get there eventually. I got a smaller setup. So here we have complete bilateral study. The next code is a unilateral. So we know they did both sides. So 93880 is going to be the code that we need. And then your diagnosis, clinical symptoms, rapid ventricular rate, that's not going to help us. So conclusion, there are some atherosclerotic changes. So atherosclerosis of the, and I'll pull this over in just a minute, atherosclerosis, I'm not sure I 100% like that. I think I probably would, I would have coded the stenosis. I probably wouldn't do the atherosclerosis. So let's read. So here we've got a rapid ventricular rate. That's the whole reason we've shown up. It does show a little hard plaque. So it doesn't look like this doc is really pinpointing the causative reason for the rapid ventricular rate, indicating less than, so we know they have the stenosis, indicating less than throughout both sides. So that would be an I-6523. And I think I would go on and code that, although that's somewhat incidental, and it would be secondary because it is not the reason for the presenting diagnosis, that rapid ventricular rate. There's no spectral, there's no present. There is some atherosclerotic changes. I cannot do anything with atherosclerotic change. If I put atherosclerosis into the carotids, I would somewhat be diagnosing this patient and putting words in the doc's mouth. I'm just not comfortable doing that. So because they didn't really come out with a definitive diagnosis, I'm going to go with this rapid ventricular rate. And I think if you go to I-47-2 ventricular tachycardia, that rapid ventricle rate is tachycardia, fast heart rate, and it's ventricular. So I think that's probably the safer bet. So I-47-2. I think I still would, as a second code, I would code this stenosis, narrowing of the carotid arteries. The 3 means it's bilateral, I-6523. And then also on that duplex, Remember to put your 26 modifier because you have to have your professional component. Okay, professional component for outpatient because we code for the physician. Okay, so here's another duplex. You should be okay with that. Vascular lab, arterial Doppler test. So let's kind of look at this one. So he's in for leg pain, 65-year-old female, history of coronary artery disease, complains of pain when walking. She exercises 5 minutes at 2 miles an hour. So this is the actual test that they're doing. The resting ankle to brachial index is 1.23. Brachial pressure went up from 115 to 130. The right ankle pressure dropped minimally from 142 to 132. And the left ankle pressure remains stable. So conclusion, there may be trivial arterial insufficiency, but nothing impressive here. So again, this test is not rendering a definitive diagnosis. So we're going to have to code for leg pain. And then I would go on and code for the CAD. There's just nothing more definitive here. So let's look at the actual CPT for that. 93924, non-invasive physiologic studies of the lower extremities at rest and on the treadmill. Remember how it described at such and such incline, such and such. So this would be the correct code. And it was bilateral because we have documentation of the right and the left. So 93924 would be the CPT that I would use for that. And I would put a 26 modifier on it to show professional component. Okay, moving into cardioversion. Remember, there's always some from the trenches and some tips for coding. This is electrical cardioversion. Your answers are in the book. I would do just like we're doing. We have a pre and a post-op diagnosis. You would always defer to a post-op opposed to a pre, because post means it's been evaluated and that's what they have. So that would be your diagnosis. Atrial flutter. They did an electrical cardioversion. They're giving you a little bit of history here. Then they go into the procedure, Versed. So you know that they're doing it right now. They shock them and they're trying to convert them electrically by shocking into a sinus rhythm. Okay, so that would be that one. Here is diagnostic ultrasound. Again, some good information, kind of breaking down these codes might help you with some of your notes. This is outpatient. This is ultrasound of both lower extremities because they have bilateral edema. So they're going to do an ultrasound looking at the deep venous system. There's no evidence of a deep vein thrombosis or a clot. Bilateral tib fib, greater saphenous, popliteal, those are all just the veins that they're looking at. They say because of the patient body habitus, she must be large or her legs are large or really just have a lot of edema, a lot of swelling could be it too. They don't find any gross deep vein thrombosis. So your diagnosis here, they didn't come up with anything more definitive than that bilateral edema. So that would be what your diagnosis is. And then you would find in the medicine section under ultrasound of the lower extremities. Remember your 26 modifier for professional component. Okay, codes elsewhere. This is remember when we first looked at medicine section, it's a little bit of a catch-all and it's just really kind of a tough section to find stuff in. Some good stuff here. This is some guidance on your diagnosing. Keep in mind, anytime you code out of the G30, in fact, I just talked to an employee on my team, one of the folks under me. about this today. And she was not aware, and she is now. So in your ICD-10, your G30, when you go to G30, you have to, this red, use additional code to identify. That means if you're using a code from here, you also need to find a code from here. So if you have an Alzheimer's patient that does not have any documented behavioral issues, you're going to code that F028. If you do have an Alzheimer's patient that has behavioral disturbances, wandering, aggressive moments, that type of stuff, then you're going to use F0281. Okay, just a little bit of tidbit, because to code Alzheimer's, you've got to have two codes, and some folks don't know that, and that's kind of what they're talking about here. Okay, moving on. Cognitive function test. This is going to go hand in hand with Alzheimer's, trying to determine neurological behavior, cognitive function, that kind of thing. Here are more health behavior assessments, health and behavior assessments, same type of thing. Then we go into chemotherapy. This gives, again, good guidance separate from the hydration codes. So I want to code this one because we're going to have to code from the CPT and from the HCPCS, because the HCPCS is where we get our meds from. So let's look here. Patient's 40 years old, multiple myeloma, so that's a form of cancer. She presents 50 minutes infusion of, I can't even read that, carmustine, 100 milligrams, chemotherapy administration. So let's get into our CPT and find those. I'm going to try to not go. Here we go. I got there faster this time. Here's our chemotherapy meds. So let's see what our scenario is again. So we did 50 minutes infusion. 50 minutes infusion. So it's chemotherapy infusion. So that's IV. So we have to kind of, right, 50-minute infusion. Okay. So we have to just kind of look here. So this is sub-Q and IM. So that's not an infusion. This is intralesional. That's straight into the lesion. Oh. And again, whoops, sorry about that. If I were you, I would go through and underline these differences, because then you can rapidly see, like all of these are indented under the intralesional, so I wouldn't even mess with them, because you might on accident see IV here, not pick up the push, and think that that was something different, but it's really intralesional. So chemotherapy administration, here we go. IV infusion technique up to an hour, single or initial substance. Well, we know only that one substance was put in, so the 96413 would be the way to go. So that's our chemotherapy. So now we've got to go to, I got a lot of manuals here. So now we've got to go to the carmustine, and I can't tell you the best way. We want infusion, carmustine. I want to just verify the spelling of that. And I got to get to the right. We got to get to chemotherapy drugs. So I'm kind of looking for my headings. Here's my chemotherapy drugs. I'm going to find, what is the, you know what, we may have to Google. That's what I do sometimes for these drugs. I have to Google, and it may not even, oh, here we go. It's on over in real chemotherapy. Where was I? Why did I read that? Chemotherapy, oh, oral. See, don't do what I just did. So keep going. So here's our injectables. So, okay, so we want carmustine, J9050, 100 milligrams. What is this? Infusion carmustine, 100 milligrams. So there we go. That's our drug, J9050. So for me, I've got to come over here and underline this because my eyes didn't pick up that these are oral. So I would have eventually read it, but still, it got me there faster. Okay, so now you would go into your ICD-10 for your multiple myeloma. Remember, you work from back, so I'm going to go to myeloma. M-Y-E-L-O. M-Y-E-L-O. Myeloma. Here we go. Multiple myeloma is C90.0, and it has a dash and a check mark. So we've got to go verify that code and find the rest of the code. This is not a complete code. So C90.0, C90.0, 90.0, multiple myeloma. So C90.0, multiple myeloma, so we're in the right place, but I've got to pick one of these codes up underneath here. So did my documentation tell me it was multiple myeloma not having achieved remission, multiple myeloma in remission, or multiple myeloma in relapse? All I have is multiple myeloma, and they're currently receiving treatment. So I'm going to go with C90.00, multiple myeloma not otherwise specified, because that's kind of the generic one, and I don't have any other documentation. Okay, so moving on, we did that one. Good for us. Sometimes those infusions, some people, it's easy for them, some it is not. Okay, photodynamic therapy. This is good information. Sometimes I do actually write in some meds if they're very, very specific to that type of procedure. And I write in, like for backs, if they put in a synthetic disc, I write the name brands of those, because sometimes in the op reports, that's what you see, is the name brand, and so it helps me. So this is going to be, patient has actinic keratosis on their lip, and they're going to receive some phototherapy for it. Physical medicine and rehab, this is your physical therapy. The physical therapy generally is a little bit easier. It's only a few codes to pick from, and you just kind of plug it in. So you should, I think you'll be okay on these. This case 20 has several steps to it, so just keep that in mind. This is a great reminder of the HCPCS modifiers. Remember, in the front of your CPT, you also have a few of those reminders here. Okay, so there's a couple of places that you can see that. From the trenches is always good advice, or at least makes you feel better about yourself. Office procedure here. These are ingrown toenails of both great toes, bilateral. Same diagnosis. Remember, you always pick your post for your diagnosis, so that's where your diagnosis is going to come from. And then essentially, I think they're cutting into the ingrown toes. So that should be pretty easy, pretty straightforward. And then your 21B is the same patient. It's the progress note. So remember on your toes to use these modifiers. If it's the right great toe then here, it'd be T5. If it's the left great toe, it'd be TA. T for toe, F for fingers. That's how I remember it. Okay? Very good. And then we're into our auditing. So we have whipped another chapter. This is good. So next video will be radiology, chapter 3.